When will we insert gastrostomy tubes for enteral nutrition? Well, always when we can use oral or enteral feeding, this is always preferred to the parenteral feeding. So basically, if the gut works, use this for feeding. Because in this way, we will avoid complications of liver disease, which are related to intravenous nutrition. We will also avoid infections related to the central catheter, electrolyte disturbances, and metabolic disorders related to parenteral nutrition. However, there are some problems because in Belgium, unfortunately, parenteral nutrition is still cheaper than enteral nutrition. If you look at the monthly cost of parenteral nutrition, this is only 18 euros a month, while this adds up to 300 euros a month for enteral nutrition. So this should be corrected hopefully soon. Moreover, parenteral nutrition is often better tolerated than the patient and doesn't require the insertion of a percutaneous tube. So you will see that many patients still prefer parenteral nutrition, but we as physicians, we should still advocate to go for enteral nutrition via a nasogastric tube, nasojejunal tube, or a percutaneous tube. So in which patients do we consider to administer enteral feeding? Of course, patients with head and neck cancer or upper GI cancer. And this can be both prophylactic, this means before they will undergo a treatment like radiochemotherapy, because we know that the therapy itself can introduce this kind of mucositis that you can see here. This will have a negative effect on food intake, the nutritional state, and also on the oncological outcome even of these patients, including survival. Also, if there is a tumor, for example, here in the tonsilla, this can block a normal swallowing function, and this will also lead to malnutrition and so on. Other indications for cancer include an obstruction or a stenosis of the GI tract, which can block the food bolus. A big group of patients suffer from neurodegenerative disorders like ALS and Parkinson's disease. In Leuven, we have a big group of patients also with primary motility disorders, patients with dysphagia, patients with delayed gastric emptying or gastroparesis. Also patients with secondary anorexia, secondary to treatments that they receive, for example, for oncological problems or other causes. Sometimes also even for primary anorexia, but every time in very close discussion with the psychiatrist. Patients with a malnutrition state secondary to cardiorespiratory conditions, so cardiac failure and so on, and patients in whom there is a limited state of malabsorption. This has been clearly demonstrated in trials. A very controversial indication is dementia. And this is always a very difficult group in whom we need to carefully think whether they need a percutaneous tube or not. And a couple of years back, Aspen devised these guidelines. However, to be honest, I don't think they are very helpful. They say that for each patient, the decision to insert a percutaneous tube should be individualized, and also that the percutaneous tube and enteral feeding can be started in patients with dementia, but only to overcome a temporary crisis. However, Aspen does recommend against using enteral feeding in patients with more advanced severe dementia indeed. And we know from the literature that patients who had a PEG tube, those with dementia, they have a poor survival compared to those without dementia. And also patients with dementia who had a PEG tube inserted and who were started on enteral feeding, they have no better prognosis than those patients who did not have extra enteral feeding. So be careful when to start feeding in these patients.
Here I will show some cases. This is an 88-year-old lady who presented with acute food bolus impaction. Of course, here the push technique would not be successful and even would create a risk of perforation. After many times piecemeal removal, we see this huge neoplasia. It was a spinocellular tumor. Here, an acute case of food bolus impaction, sometimes not even with meat or anything. In this case, with bread. But this patient, he's received a distal esophagectomy for tumor 1 year ago, and you see an stenosis of the anastomose. We cannot forget also the delayed cases, because they are the ones that we see more risk. This patient, 83-year-old, she was complaining with pain in the upper throat, but because she had a dementia, she could not, of course, give the history with clarity. So in this case, they took out the fish bone, and they saw a perforation afterwards. The risk of perforation is increased if the object is there for a long time, and afterwards it was shown that there was indeed air, but they closed immediately in the endoscopy with clip. Also another case, delayed. Old lady didn't have any history of food bolus impaction, of difficulty, but complained of abdominal pain. In at CT scan, that shows an abscess and a radiopac image between the liver and the stomach, and it was a fish bone also that was removed with surgery. Another case of abscess with a chicken bone that is impacted in colon ascendance. And we cannot forget also to perform a completely examination. This patient had a case that she had a food bolus impaction with olives. Because her stomach was full, we could not check everything. But afterwards, she appeared in emergency with pain in the abdomen, and the toothpick of the olive was there. We will have sometimes to ask the surgeon to help us, especially in the case of perforation, peritonitis, bleeding, small bowel obstruction, and also when the food bolus, and when I say food, it is not only the non-bony, but it is also the bone and the fish bones, because they can be out of reach. There is a possibility of watchful waiting if there is no sign of complications. You have to do daily radiographies, and you have to also say to the patient to see the feces to check if everything is passed. But of course, in case of complication, surgery is the treatment, and is the way to go.
There is a question from the audience, and they are asking whether you should use glucagon in case of food bolus impaction.
I used to do the endoscopy always. I can give the order to the ER doctor, for example, to administer glucagon. If I will not be able to do it immediately, the endoscopy, it eases the passage to the stomach, and in the stomach is always easier to take out, to remove the food bolus, but I would definitely not delay if I can immediately go to the endoscopy, because I need to see what is underlying. It is not that if it's passed, I still want to follow these patients in order to diagnose pathology.
That's clear. So we go and have a look.
Maybe just one question, well, something just to mention. Tim, you mentioned the replacement of the balloon catheter after the first 8 weeks, but what about the future follow-up?
Yes, indeed. So the thing is, the tract forms after 1 or 2 weeks. However, this can be compromised in case of diabetes, in case of treatment with corticosteroids, bad nutritional state, as most of these patients have. So to be on the safe side, you should wait at least 1 month to replace the tube blindly without endoscopy. If the tube would fall out between 2 and 4 weeks, then you can do it, but it's better, you can do it blindly, but then you should check radiologically. If it is within the first 2 weeks, then you need an endoscopy to make sure you put in the guide wire and you carefully insert it. Or if it's really a peritonitis, peritoneal sign abdomen, then you go for surgery.
And do you routinely replace the balloon catheter after 3 to 4 months because of the possible degradation of the balloon, or
The first balloon, definitely, of the PEG-ZACT,
but not afterwards?